Hollis is an associate professor. Dr. Ian Hollis is an associate professor in the Department of Pharmacotherapy and Experimental Therapeutics at the University of North Carolina Eshelman School of Pharmacy. He was also a clinical pharmacy specialist in advanced heart failure at the University of North Carolina Medical Center for 17 years. He will be presenting today on updates in mechanical circulatory support. Our second speaker is Dr. Yian Chen. She is a cardiology clinical pharmacy specialist with expertise in advanced heart failure at the University of Rochester Medical Center. She will be presenting today updates in heart transplantation. And then our third speaker is Dr. Zena Huang. She is an assistant professor of pharmacy practice at the Arnold and Marie Schwartz College of Pharmacy at Long Island University. She is also a heart transplant clinical pharmacist at New York Presbyterian Hospital, Columbia University Irvine Medical Center. And today she will be presenting updates in lung transplantation. So with that, I will turn our webinar over to our first speaker, Dr. Hollis.
All right, thank you. I'll go ahead and jump in and let me close this slide and get over to my slides. So I'll be doing the portion of today's presentation about mechanical circulatory support from the ISHLT meeting. And sorry, let me get, there we go. So I don't have any disclosures related to any of the content that I'll be presenting today. I'm going to go through two studies from the meeting. One of them was a pretty big deal. I'll start with that one. It's called the apixavad study. And so one of the real areas of interest in durable MCS management is whether or not we can use DOACs and get away from warfarin. And so the apixavad study was presented as one of the late breakers and then actually published in JHLT simultaneously. And so you can see here the general overview of the study. So patients had a HeartMate 3 LVAD placed, and this was two centers, one in Switzerland and one in Australia. And the patients had to go through a minimum period of 2 months of warfarin before they could be switched. So the early postoperative period was still vitamin K antagonist. And then you can see half the patients were switched to apixaban at 2.5 BID, and that's what makes this study interesting. The authors cite some data they have from some ex vivo studies using mock circulatory loops where they felt like the drug levels and the amount of therapeutic anticoagulation you can achieve with 2.5 of apixaban is comparable to a therapeutic INR in that setting. It's also worth noting none of the patients in this study actually met the AFib dose reduction criteria. So these are all patients who would have otherwise gotten 5 BID. And so you can see the goal is for this study to run for 2 years. This was a 6-month interim analysis that was presented. And so some of the baseline characteristics are notable relative to patients we would take care of here in the United States. They're a little bit younger, as you can see, because a lot of them are bridged to transplant, which is common of VAD patients in Europe. Overwhelmingly male and Caucasian, which does limit our ability to extrapolate to American patients. The time and therapeutic range, you can see, was striking. Patients had to have a TTR of 60% at baseline to be able to be enrolled in the study in the first place. Now, considering in most American cohorts, the TTR is barely 50%, again, these are not exactly like the patients we're taking care of. A lot of aspirin use, a lot of ACE-ARB ARNI, a lot of AFib. The average GFR, the cutoff was 60. They couldn't be below 60, but the average was mid-60s in the study. And so what were the outcomes? Well, the primary outcome was a composite of what in VAD land we call hemocompatibility-related adverse events, which is just a mix of all thrombotic or bleeding events that could occur. And so along with death added to that as well. And the study went on until the patients had their first primary outcome event or got transplanted or will get to 24 months of follow-up. And so the initial publication, which again is in JHLT from around the time of the meeting, shows that the primary endpoint was very similar between groups and certainly no worse with apixaban relative to vitamin K antagonists. The events were generally bleeding, and they generally occurred in patients who were also taking aspirin. Patients started the trial on aspirin, and then when ARES was published, they started to discontinue or not start aspirin in subsequent patients. So it's sort of a mix, but we can see apixaban is certainly no worse at 2.5 BID. Now, I want to pause for a second and take a look at what we now know about apixaban in durable HeartMate 3 LVAD. So we have three studies really in the last 12 months. And so a quick summary of these studies on this slide shows you that we're close now to about 120 patients who were in these prospective studies of either apixaban or vitamin K antagonist. You can see none of them are at the time of LVAD. There's always this cushion period of vitamin K antagonist before the DOAC begins. Apixavad was the first one to use 2.5 BID, which makes it interesting. Aspirin use across these trials was mixed and non-standardized. So far, we've only got about 6 months of follow-up in each of these studies, but importantly, no thrombotic events, no pump thrombosis or other thrombotic events in any of the patients treated with apixaban across these three studies over 6 months of follow-up. And so pretty noteworthy at this point. So because this is a joint webinar with the transplant PRN, I wanted to talk about the patients who went from HeartMate 3 to heart transplant because, of course, this is the elephant in the room. If we're going to use apixaban routinely, how do we manage a time-sensitive heart transplantation? So in DOT-HM3, which was a study done in Europe, published about a year ago, where they used 5 BID of apixaban, 8 of the patients in that study went to heart transplant, and you can see their protocol involved PCCs, a cytokine absorption system, which I'm going to talk more about in a second, and then other blood factor components, as you would expect. Now, 8 out of the 8 patients who got a heart transplant in the DOT-HM3 study required PCCs. 7 out of the 8 got put on this cytokine absorption system while they were in the operating room. But what's notable is the other products. On average, these 8 patients required nearly 11 units of red blood cells, nearly 16 units of FFP, and 6 units of platelets. Many of them had their chests left open after the OR, and the median hospital stay after transplant was 45 days. And so this is not going to be able to become standard of care. This is concerning for a potential world where all of these patients come to transplant on apixaban. Now, what can we learn from DOAC LVAD, which was done in the US, about transplant? Not much. None of those patients went to transplant during the study period. So apixavad, the study I'm talking about today, very similar perioperative protocol, but on 2.5 BID of apixaban, which was held on average for about 20 hours prior to the surgical procedure. The packed red blood cell use was only 2.5 units on average. They did get 6 units of cryo, but only 4 of FFP and 2 of platelets along with PCCs. So much more acceptable, much more something that we'd be able to do routinely heading into heart transplant. So I think that's pretty interesting. And again, something that we could live with more routinely. Now, what is this cytokine absorption system? I find this fascinating. It is basically a chemical filter that you can place into the cardiopulmonary bypass circuit. It has these specially chemically designed beads that will extract certain antithrombotic medications from the blood as it filters across the system. And so you can see it will take rivaroxaban, apixaban, and or ticagrelor out, depending on the configuration. So obviously, we're most interested in apixaban. And what you can do is you basically line this into the bypass circuit and you start running the patient's blood through it while they're on the bypass machine, and that filtration can occur. In ex vivo mock circulatory loops, and so this is not real humans, but basically a mock setup, what you can see here is that patients who got put on this device had the vast majority of their DOAC removed within 60 minutes of beginning this process. Now, is that real life? Data from actual humans, from case reports shows that the filtration process may take longer than that. This is about a 6-hour period of a patient receiving a heart transplant where the circulatory loop was running in the background. And you can see it took till about the end of the case to get below 50 nanograms per ml, which is generally considered to be the minimum therapeutic dose or level of apixaban. So probably beneficial. How quickly does it work? We're not yet sure. It's also mostly available in Europe and isn't really available in the US yet, so that's a bit of a problem. But it's exciting. And so I think moving forward, thinking about apixaban, we have more data that it's safe even at lower doses. The lower doses may produce less bleeding at the time of an eventual operation. And so I think talking with people at the meeting, there was a general sense that people are starting to dabble with apixaban, and some centers are starting to use this in some of their patients. So I think we're going to get a lot more experience soon. The other paper I want to talk about today, or the other presentation, was about bivalirudin as compared to heparin for patients with an Impella device. And so this was a two-center study, also done in Europe, which was observational. One center was in Germany and the other was in Italy. And so they looked at all patients with cardiogenic shock who were supported with an Impella. They had to be on the device for at least a full 24 hours. They couldn't be using another MCS device, so there was no ECPella arrangements, if you will. And it wasn't post-cardiac surgery. So the majority of these patients are either acute on chronic heart failure or acute heart failure due to a myocardial infarction. And so um, the study endpoints and the premise of this study was that we've got other data from ECMO that shows that bivalirudin could possibly be a little bit better relative to heparin in preventing hemocompatibility events and improving overall endpoints. And so that was the premise of moving this over to the Impella device. And so the endpoints, they wanted to look at, bleeding and thrombotic events, the incidence of hemolysis, which is a common complication with Impella, and then look at the management of the agents in terms of supertherapeutic APTTs and overall survival. Now they had raw data, but these patients were not perfectly matched at baseline. And so they tried to use a process they call inverse probability weighting to account for these baseline disparities. And this is where you basically do a logistic regression model, and it estimates the probability of getting one drug or another based on some of the patient's baseline characteristics. And then it weights that likelihood against the overall raw number of endpoints to create an adjusted endpoint rate ratio based on this weighting. It's complicated. I'm not going to pretend to completely understand it, but this is the process that they use. So they got 180 patients split fairly evenly between bivalirudin and heparin. And you can see some of the baseline characteristics there. We had a split between chronic heart failure versus an acute MI. And you can see the types of Impellas they used were different as well, because it was over a period where the types of devices most commonly used were evolving. On average, the patients had the Impella for about 8 days. Um, the lowest platelet count during the device use was lower in the bivalirudin group. There was more dual antiplatelet therapy use in the bivalirudin group, which may reflect a difference in the reason for the Impella in the first place, which would be the myocardial infarction as opposed to heart failure. And so the raw results show that the rates of bleeding, although numerically more with heparin, were not statistically significant. Device thrombosis, a little bit numerically more with heparin, but again, not significant. Major hemolysis was no different. And then if you look at upper right, the raw 30-day survival was no different between these two groups. Now, APTTs deemed to be super therapeutic, meaning greater than 80 seconds, happen significantly more often with heparin, and variations between checks. So from one check to the next were more likely to occur with unfractionated heparin, which perhaps isn't surprising. Um, Now, the inverse probability weighted analysis showed that you were more likely to survive to 30 days if you received bivalirudin. And so the risk ratio was 1.19. Again, with all of the weighting done and the logistic regression. Now, from the presentation at ISHLT, it is not clear what factors went into that analysis in terms of predicting which therapy the patients received. So we'll still have to wait for the publication to get more information on that. And so it does appear, at least from this analysis, that perhaps, I say these things cautiously, that bivalirudin may be a little bit more beneficial in terms of manageability of the drug and potentially 30-day outcomes. Although I feel like we need a prospective randomized study where the patients are evenly matched at baseline to be able to conclusively say we're ready to move to bivalirudin more commonly. And so I will pause there. We are going to take questions at the end, so I am going to turn it over to our next speaker.
Great, thank you, Ian. Hi, everyone. My name is Yan Chen, and I'm an advanced heart failure pharmacist at URMC. And I will be talking about the use of daratumumab for antibody-mediated rejection in heart transplant, with a focus on one oral session from ISHLT, along with highlighting a couple of posters on this topic. I have no disclosures. And I'd like to start off with a quick overview of antibody-mediated rejection, or AMR, targets to see where daratumumab fits. So in transplant immunology, there are a variety of pathways and mechanisms in which AMR can occur, and thus there are many targets to try and treat AMR. So for example, targeting CD20 on B cells utilizing rituximab, although that doesn't really target your long-lived plasma cells, you may want to consider agents such as tocilizumab as an anti-IL-6 or bortezomib as a proteasome inhibitor, or even potentially looking at the complement cascade and utilizing an anti-C5 such as eculizumab. And where daratumumab comes in is that it serves as a CD38 inhibitor. A little bit more about daratumumab's mechanism of action. Daratumumab, or Dara as I'll shorten in this talk, is a monoclonal antibody directed against CD38, which is a transmembrane glycoprotein that's on plasma cells, along with some subsets of lymphocytes, such as NK cells. And as a result of this, leads to complement-dependent and antibody-dependent cytotoxicities, antibody-dependent phagocytosis, and apoptotic signaling. On the upper right there, you do see that there is a potential for depletion of regulatory cells. And so with this is a theoretical risk of potentially, while treating AMR, you may have the increased risk of T cell mediated rejection. And I thought it was pretty interesting. There was actually a poster at ISHLT by Ferguson and others from Tufts that was a case report of a patient that had light chain amyloid being treated with Dara-Cybor-D, and the last dose of Dara being 2 weeks prior to heart transplant. And 2 weeks after the heart transplant, essentially had 2R acute cellular rejection that was recurrent. And so this patient had actually only received steroids, no other induction prior to transplant. And so the authors were suggesting that maybe patients who receive Dara may need to have a little bit more of an intense induction, for example, with thymoglobulin. So I thought that was interesting in thinking about how the mechanism of action of Dara plays a role in our transplant patients. So the major study that I wanted to talk about is called Impact with Daratumumab on Antibody-Mediated Rejection in Heart Transplant Recipients, which was a study by Dr. Sherwatana Komen and from the Centers of University of Pittsburgh and Beth Israel. In this study, it was a retrospective review at 2 institutions studying heart transplant recipients with either early antibody-mediated rejection, defined as within 2 weeks of transplant, or late chronic AMR with persistent DSA. And the treatment was weekly daratumumab at 16 mg per kilo doses, which is the same dosing as that we use for multiple myeloma. The 2 study outcomes were biopsy antibody-mediated rejection grade pre and post Dara, along with the MFI, or beam fluorescence intensity, of the immunodominant DSAs, in which these were defined as 50% reduction in the MFI at the respective dilutions. There were 8 patients in this study, 4 that had early AMR and 4 with the chronic. 5 of the patients from this group had biopsy actually conducted, and all of them had at least 1 AMR grade reduction. 1 patient had donor-derived cell-free DNA that was normalized following DARA. And the majority of the patients and a majority of DSAs had responded to DARA with an average MFI decrease of 67%. Of the 4 patients that had chronic AMR, they basically all received treatments prior to DARA with no AMR grade improvement, nor significant MFI reduction, compared to a 56 decrease reduction with daratumumab. So with a study that has such a low number of patients, which is a lot of our heart transplant studies, I thought it might be easier to actually look at each of the patients and what exactly happened with more detail. And so the authors actually did present this nice table, which I'll walk through. It is a lot of information, so I'll orient you and help walk us through this. So I focus your attention to the first 4 patients up at the top. These are our 4 patients with early AMR within the 2 weeks of transplant. You can see that prior to DARA, they really only received at most plasmapheresis. 1 patient had IVIG as well. And the majority of the patients didn't have really any AMR signs, no dysfunction. And so 1 patient had high filling pressures and low output. Otherwise, these patients really fit the criteria due to just having AMR grading of 1 or 2. And in 1 patient, there wasn't even a pre-DARA biopsy. It was just mostly looking at the DSAs. The number of DARA doses you can see ranged widely from just 1 dose to 11 doses, and all of the patients afterwards had a PAMR of 0. For the immunodominant DSA, the MFIs ranged from around 4,000 to 14,000, and then after DARA had a percent decrease of between 64 to 97, and all 4 patients had stable allografts after. And so just inserting some of my preliminary thoughts in here, I think, none of the patients really had that significant graft dysfunction prior to treatment, and we're just targeting the biopsy results and mostly seemingly the DSAs that we're really targeting here. And all of the patients didn't really have any other agents that were used other than plasmapheresis, and most of them even get IVIG. And so those were just a couple of the thoughts as to, it looks like DARA did its job here with reducing the AMR biopsy results and DSAs, but was that really clinically significant? Was that super necessary for these patients, so to speak, especially without having graft dysfunction? Now looking at the bottom of the table, these are our 4 chronic AMR patients. You can see that the pre-DARA treatment was a lot more significant here. In addition to Plex and IVIG, a lot of these patients received carfilzomib or bortezomib, along with belatacept, rituximab, thymo, eculizumab. So a little bit more of a wide variety of agents used prior to reaching for DARA. 2 patients didn't really have any signs of AMR, but 2 patients did have shock and VA ECMO, again, with a variety number of DARA doses, although I will say that the patient that had received just 1 daratumumab dose, you can see that there was no biopsy after DARA, and the patient was actually deceased after. And so I think my best guess what happened with this patient was that they did not live long enough for a follow-up for that. And so almost excluding that patient, majority of these patients received a much higher number of DARA doses. These patients had a PAMR pre-DARA of 1 or 2, and 1 patient you can see had cell-free DNA of 1.51%. That was decreased to 0.14% afterwards, along with improvement in the biopsy for the other patients. The immunodominant DSA MFIs were a lot higher for these patients, especially with their respective dilutions, and had a percent decrease that ranged from a little bit lower, like 30% up to 70%. And then 3 out of the 4 patients had stable allografts after. So the DSAs for the chronic AMR patients can also be highlighted in a separate graph that might be a little bit easier to see. So this is only the chronic AMR patients, and the different color line represents the different DSAs, and the MFIs are in the y-axis. On the left-hand side of the graph is essentially pre-DARA treatment. So what they tried before, you can see there's no significant difference in the MFI of the DSAs. But on the right side of the graph, you can see that with DARA had a significant improvement in decrease of these DSAs. For adverse events, the authors reported viral infections in 4 patients, and this included shingles, CMV, norovirus, influenza, and COVID, along with 1 patient with transient neutropenia. So conclusions from this trial that the author had was that DARA significantly improved AMR and reduced DSAs, including patients who had failed other treatments and had also high titer DSAs. There were a variety number of weekly daratumumab doses, and you may need more number of doses to decrease DSAs with higher titer antibodies. But of course, as we hope for all heart transplant studies, ideally randomized controlled trials to compare DARA with other AMR treatments, along with larger studies with longer follow-ups would be really nice to see. So I kind of told you some of my initial thoughts based on the chart, but some of my other thoughts about it and questions that I have pending when the paper would be published, I would love to read more about was from a logistical standpoint and as a pharmacist that would think about using this drug, how was the daratumumab administered? Was it IV or is it sub-Q? And with that, did the patients that received that many number of doses, for example, like 13, did they stay inpatient this whole time, or were they mostly waiting outpatient receiving sub-Q injections? And what would be the cost implications for that? Did they give pre-medications? Would love to know like the protocol for using daratumumab. From a clinical standpoint, would love to see what the dosing strategies of the previous AMR treatments are. When using thymo, like what dosing strategy did they use? How much of a cumulative dosing were they using? How many rounds of those treatments? What was their immunosuppression regimen? What were the tacro levels like? And for these patients, especially with the early AMR, did they receive induction? And how would that have maybe affected both the efficacy and also the safety outcomes as well? And lastly, looking at those safety outcomes, which patients of those 8 were the ones that got infected? Was it the people that received a much higher number of doses of DARA? And also, what is the time frame? Did they get sick right after a single dose, or did it happen weeks or months after? I think hopefully some of those questions can be answered when the paper comes out. For the remaining time, I just wanted to briefly touch on a couple of posters that talked about daratumumab as well. This was a poster by Sarkis and others from Mayo Clinic, similar in that it was a case series looking at refractory AMR treated with specifically sub-Q daratumumab. And these patients, you can see, also had a variety of treatments prior to trialing DARA, and in this case did not really report on looking at DSAs, but specifically looking at just biopsy results. You can see mostly a resolution to an PAMR of 0 after DARA. This was another poster by Nara Simaraj, also from the same institutions as the first trial from BI in Pittsburgh. This was a case report looking at a 54-year-old male that had a dual heart kidney coming in with cardiogenic shock, concerning for severe mixed rejection requiring VA ECMO, and essentially looking at the DSA MFIs that with a variety of treatments, steroids, thymo, plex, bortezomib, eculizumab, these DSAs still had only minor improvement and then increase again. And the authors did note that with these treatments, there were clinical improvement, but persistently elevated DSAs. And it was only after switching to DARA that there was a marked DSA response. And the last poster is by Bill Gilly and others from Tampa Hospital, that this talked about 4 cases of DARA, also with refractory DSAs. So kind of similar in looking at these different lines being different DSAs, and then looking at how daratumumab essentially helped with the resolution of these DSAs. Of note, though, there was that one patient in the yellow that had a DSA rebound. So that's kind of interesting maybe to see like what happened with that patient and maybe what other treatments did they have prior. And it seemed like maybe they used IV DARA in this case because they reported 2 patients having recurrent infusion reactions, only tolerating a max rate of 67 mLs an hour. That concludes my presentation. And in summary, I think daratumumab is gaining a lot of traction in the heart transplant AMR space. I will say that currently at Rochester, we don't use it yet. But if I were to think about where it could play a role is especially where most of the data is looking at in refractory AMR and also in persistently elevated DSAs in patients. But after all the presentations, when we talk through Q&A, I would love to hear from anyone from the audience if you utilize DARA in your institution protocol for AMR and also any clinical pearls that you may have. Thank you. And I'll turn it over to Zena.
All right, thank you, Ian. Good afternoon, everyone. My name is Zena Huang. It was actually my first time attending ISHLT, so it's my great honor to share a recap invited by the CCP PRNs about lung transplantation. I would like to focus on the highlights that are pertinent to pharmacists who are caring for lung transplantations. I have no financial disclosures, and some of the studies we'll be discussing, like most transplant studies, will involve investigational drug use and off-label medication uses. So for the content from the ISHLT 2025, I think the key themes that I've identified include CLAD or BLAD, donor management, specifically ex vivo and DCD outcomes. There's a lot on infections, pharmacological management, and I think there's an emerging interest in multi-organ transplantation as well. Personally, I don't think there's anything that's groundbreaking, but I would like to highlight a couple of studies that involves specifically infections, pharmacological management, and multi-organ transplant, since CLAD was intensively discussed at the last recap from ACCP PRNs. All right, we'll begin with fighting the fungi and ongoing challenge of lung transplantation. So I'd like to start with a presentation that were reported on olorofim, which is a novel antifungal agent under investigational use currently. So the mechanism of that, instead of targeting the cell walls or the cell membranes, olorofim actually inhibits mitochondrial dihydroxyoctane dehydrogenase, which interrupt the fungal pyrimidine synthesis. So this study was essentially a sub-analysis from a phase 2 study that they focused specifically on lung transplantation in this group, and they investigated that use in invasive mold infections. And specifically, they looked at CD36 patients, with 15 of them required extended therapy beyond that 12 weeks investigation time. And I do want to note that there's almost 60% of the cases were actually azole-susceptible aspergillosis infections. And the outcomes that were reported, there were a 47% of response rate at 6 weeks, and about 42% response rate at 12 weeks. And the study group reported that this drug was generally well tolerated, with only one patient reported liver injury. So overall, my thoughts on this presentation is that olorofim is an investigational drug that could potentially offer an option for the lung transplant patients who have difficult to treat mold infections, and it seems to be a safe and easy option since it's oral. Moving on to the next study, which talks about azole or prophylactic use of antifungals, which is a single-center retrospective study that compared the 3 azole antifungal prophylaxis, which are voriconazole, posaconazole, and isavuconazole. So they looked at breakthrough infections while the patients on prophylaxis, and They're very similar. Around 5 to 6% of patients break through having invasive fungal infection while on the prophylaxis. However, when you look at the adverse reaction outcomes, it looks like voriconazole groups have a lot of adverse reactions as expected, especially altered mental status, which happened in almost 33% of the patient. And surprisingly, there's also a higher incidence of probable biopsy-proven rejection and even clad in the voriconazole group and also posaconazole group. Interestingly enough, there's isavuconazole, there's fewer adverse reaction reported and no acute rejection episode reported. So looking at this study is suggesting that for those centers who are not comfortable with using isavuconazole, this study suggests it might be a reasonable alternative to our good and old voriconazole and posaconazole, especially in those who cannot tolerate the voricanazoles. Okay, we're switching gear to taming tacrolimus, where strategies to reduce tacrolimus toxicities. So we'll start with a novel way of delivering tacrolimus. So this is a open label study that looked at tacrolimus inhalation powder. So they looked at this novel way of delivering tacrolimus in lung transplant patients who are at least 6 months away from their transplant and have eGFR less than 45. They included a total of 14 patients, and they wanted the patients to stay on this inhalation tacrolimus for at least 3 months with extension to over a year if possible. And how they deliver this tacrolimus powder is through a simple handheld inhaler. And the study group wanted to target a 50 to 60% of the blood level compared to the oral systemic use. What they found was that, well, first of all, for the safety outcomes, there is only one acute rejection, one rejection that was reported out of the 14 patients. And it looks like for the eGFR standpoint, the patient remains to have a eGFR about 42, which is pretty comparable to pre-tacrolimus inhalation period. From a PK standpoint, the study group reported that it seems like the bioavailability of the tacrolimus inhalation is good, and they also find there's a reasonable amount of intra-patient variability when you do the inhalation. So I think this study explored a very novel way of delivering tacrolimus that could potentially be renal sparing or at least renal function preserving if we delivered it this way as opposed to deliver it orally. Now we're going to talk about belatacept, which actually generated a considerable amount of interest this year. So we'll be talking about a couple of presentations and posters that focus on belatacept renal sparing strategies. So we'll start off with actually 2 presentations, but presented by the same group that talked about a multi-center retrospective study by University of Florida that evaluated 160 lung transplant patients receiving belatacept, but with 66 of them included in a subgroup analysis that looked at those who already have de novo DSA prior to belatacept switch. So incidentally, those lung transplant patients were transitioned to belatacept around month 9 after their transplant for a renal sparing purpose. And they were compared to a cohort of matched controls who stayed on the traditional calcineurin inhibitors. What they found was that the creatinine definitely improved for those who stayed on belatacept. So the serum creatinine improved by 0.2 in the belatacept group versus there's a 0.7 increase in those who stayed on calcineurin inhibitors. And you do not have to pay the cost of increased rejection since the rejection rate between those two groups are similar. However, what's concerning a bit to me is that there's a higher mortality rate in the belatacept group. It's 32% in Bela group versus 20% in the controls. And the study group believed that the main drivers of this difference in mortality was malignancy and clad specifically. For the subgroup analysis that they did, looking at 66 patients who had de novo DSA prior to Bela initiation, they did find like no patient who already had AMR. Half of them have AMR prior to Bela initiation. There were no one developed AMR while they're on belatacept infusions. And and almost all of the DSAs get resolved during the belatacept infusion period. There's no difference in the incidence of clad infection or malignancy, specifically in this subgroup analysis. So I think looking at this study overall, I think it highlighted belatacept's potential to be used definitely as renal sparing strategy and potentially very beneficial for DSA resolution. However, I do have the concerns looking at those long-term outcomes, specifically related to the increase in mortality, malignancy, and clad. There are also some posters on belatacept renal sparing strategies from the NYU group, U Chicago, and U Alabama Birmingham. I want to highlight the studies carried by Masikas et al. At NYU that specifically compared belatacept versus sirolimus as renal sparing strategy. So for those who stayed on a low-dose tacrolimus, when you compare Bela versus sirolimus, it looks like the renal outcomes at 1 year are both preserved. You'll compare the 1 year eGFR changes, both groups had about a 5% increase from the baseline. Numerically, there's an increased rejection in the group that received belatacept, 18.2% versus 5.1% in the sirolimus group. However, that's not statistically significant. You do see much more, almost tenfold more increase in CMV viremia in belatacept, but Bela is much, much more well tolerated compared to sirolimus, which have 20% of the discontinuation rate from intolerance due to adverse reaction. The other two groups, University of Chicago and UAB, they also reported some case series of using belatacept. Well, those are limited by sample size, but we do see a consistency across those centers to encourage exploring belatacept use and dosing strategies and when to convert a patient at a time frame after the transplant. So overall, I think there are definitely more data on Bela to come, and there will be more detailed data when more and more centers are reporting their practice. Now we're going to spend the rest of the time on heart and lung transplant, or dual organ transplant, since it takes two to tango. That's my favorite section title from the ISHLT, so I have to put it on here. But we'll be talking about heart-lung transplant study, and heart-lung transplant is definitely a growing patient population as we'll see. So the first study we'll be talking about is a UNOS-based study that evaluated predictors of ECMO use within 72 hours for PGD after heart-lung transplant recipients. So they overall included 322 patients. There's 54 of them who required ECMO at the 72-hour marks. And the study have identified some key predictors of ECMO use, specifically if the patient were retransplant, if they were on ECMO use prior to transplant, longer ischemic time over 4 hours, or if they have a pre-transplant low FVC. And importantly, we do see that early ECMO use was associated with significantly worse 5-year outcomes. So I think while this study is descriptive in nature, this will help us to stratify heart-lung transplant recipients and hopefully optimize their pre-operative plannings. Lastly, I will briefly share the findings that I presented at the meeting, which is a UNO study as well, that specifically look at immune suppression strategies and outcomes in heart-lung or dual organ transplant recipients compared before and after the allocation change. So for those who are not as familiar, there is a UNOS allocation change that happened in 2028. So this study aimed to compare dual organ outcomes pre and post that policy change, and we'll be focusing on the heart-lung transplant patients specifically here. So overall, there were 236 heart-lung transplant patients included in the analysis. Well, for the baseline characteristics, there's no difference otherwise, but we do observe that the patients are sicker at baseline. Specifically, you see an increase in LAS, you see an increase in allograft ischemic time. So now we're closer to the 4 hours mark as we recognized in the other study. And we see a significant increase in ECMO use. So almost 30% of patients post-allocation change were on ECMO at the time of transplant. When it comes to immunosuppression practice patterns, we see a significantly increase in baxilizumab induction use, which is represented in red here, which is mirrored by the decrease in using no induction, we're using steroid-only induction. So after the allocation change, almost 80% of the centers utilize baxilizumab as their strategy for induction. At 1 year mark, as you can see in the table below here, most patients at 1 year for the maintenance immune suppression, they maintain on tacrolimus, mycophenolate, and corticosteroid, but we do see an increase in use of mTOR inhibitor at 1 year. Up to 15% of the patients specifically were on mTOR inhibitor at 1 year, which may be a strategy for renal sparing or for CAV prevention for heart transplant specifically. With that change in immune suppression, let's take a look at the outcomes. So there was actually no difference in the rejection rate for the heart-lung transplant patient when you compare pre versus post-allocation change. And we actually see a reduced risk of graft failure in the post-policy change era. There is no difference in infection, and we do see a comparable 1 year survival when you compare the cohort. So those findings actually reflects a evolving in practice patterns, even though we do have sicker patient or patient with greater acuity, the outcomes has not worsened. In fact, probably a little bit improved for graft failure. And those outcomes might be reflective of the refined immunosuppressive practice changes approaches. With that, that concludes the selected highlights from the ISHLT 2025. Thank you for your attention, and I'm happy to take any questions.
Thank you to Dr. Hollis, Dr. Chen, and Dr. Huang for their very informative and timely presentations today. We're happy to take any questions for any of our speakers at this time. You may unmute yourself, or you can also enter them in the chat as well. Dr. Hollis, I do have a question for you about the Apixabat study. I also found it interesting that they used a reduced 2.5 milligram dosing for this study. You mentioned that they believe that this dosing was equated to therapeutic levels. Did they do any sort of confirmatory laboratory testing to confirm that was the case?
Oh boy,
No.
yeah, that's a good question. In looking at the publication, this wasn't presented at ISHLT, but in the concomitant publication, they say they have further analysis about some of the coagulation factors coming in future publications. So I think they plan to do some of that, to do some of those studies and publish that separately.
We do have another question in the chat regarding that study as well. For the Apixabat study, how was TTR defined in the Apixaban group?
Yeah, that's a good question. I guess I should be clear. There really was no TTR for the Apixaban group. What I showed in terms of the characteristics of the patients would have been the vitamin K antagonist TTR prior to enrollment in the study. And so they had to be at or above 60% to meet criteria for enrollment during the couple of month period between the VAD and the actual randomization to one of the two study arms. But obviously, mid 80s for TTR is a world that most of us don't live in. And so it's interesting because when you look at the results where apixaban is pretty much non-inferior, I mean, it's non-inferior against the best possible presentation of warfarin management that you can imagine, right? And again, that doesn't really represent US management. And so what would it be like in older patients, more of whom were destination therapy with TTRs of 50%? You know, would apixaban actually be better over the longer term? And I think hopefully we'll find that out eventually.
That remains to be seen. These studies have short follow-ups at this time since it's they're so new.
So I'd actually like to ask the crowd, for those of you familiar with VAD management at your centers, you could just throw something in the chat. Are any of you moving towards apixaban or any of you using apixaban so far? I know we're sort of just at the conversation and discussion phase at my institution, but is anybody actually doing this?
I'll talk out loud and while people type in the chat. We have definitely not done anything with that yet, except of course for the patients that, just don't take warfarin and are, TTRs of like 5% or something, because they just won't take it and we can never get them to goal. Those are probably the main patients that we think about for. I do, like, it's a corollary statement, but a lot of our patients, we actually don't bridge at all for our HeartMate 3 LVADs. And I think our TTRs for warfarin are pretty abysmal. And we actually still see a lot more bleeding side effects compared to, any sort of clotting. And so even though it's not really the same here, like, I feel like I predict probably within the next 5 years, apixaban's gonna probably take over for LVADs. But it is very interesting that it all sort of is, maybe it's not as scary as we thought to transition to a DOAC for, mechanical circulatory support, but am curious to hear from other people.
Yeah, it's interesting you say that and you're not the first person I've heard say we'll use apixaban in patients who appear to be non-compliant or can't manage their warfarin. And I think one could argue that apixaban could actually be worse in a patient like that, right? Because if you miss a dose or two, you have basically no drug on board. Whereas I'm sure we're all familiar with those patients. We have them where I'm at, where we know they don't take their warfarin correctly and they show up to the hospitalization, but their INR is at least like 1.6 or 1.7 because they take it every now and then. So I wonder about a patient, who just goes a couple days with no apixaban and then they're really on literally nothing. Um, One of the questions in the chat was about antiplatelets, and I'm glad you asked because this is one of my favorite topics. But in the trials I showed, the aspirin use was variable. But what's interesting is when you look at the bleeding events that happened in the VAD patients who got apixaban, the vast majority of them were receiving aspirin. And so I think it's a very small cohort, but it seems to correlate what we already know about aspirin with vitamin K antagonists, which is it drastically increases the risk of bleeding events. And so I would argue if you are going to use apixaban, I would not use aspirin with it. And the question came up about ACS events within a year. Now, I don't know if you mean a year pre or a year post VAD. I think a year post, you would probably have to add some sort of antiplatelet for at least a short period. I will say, even at our center, we've been off aspirin. We kicked the habit, so to speak, several years ago, and we analyzed our own data, and we had a lot of patients who had a lot of other compelling indications for aspirin, very similar to the ARES study, and we didn't give them aspirin, even if they had had an ACS event, um, fairly recently, and it didn't show any worsening of the results, and so. As tempting as it is to want to add aspirin in these settings, I don't personally think it's a good idea because the bleeding is just too common.
Ian, you and I had talked about in the past about apixaban transitioning in our patients. We actually just started doing that 2 weeks ago. We transitioned 3 of our patients to apixaban. And interestingly enough, we've actually chosen not to start anybody who has been non-compliant on warfarin for the reasons that you stated earlier, kind of maybe a little bit more riskier side to switch those folks to a DOAC, really, not having a whole lot of information on, clotting at this time. So we're kind of dabbling in that now too. We'll see what happens over the next few months. So.
And so I think one of the things for anyone listening who's, at a transplant center, obviously, is I think to me, what's important before you begin using apixaban routinely is that you've got your reversal plans in place, mapped out, protocols on paper, everybody involved has sort of signed off. And this is what we're starting to work on is, for bleeding, what are the thresholds that would get reversal versus just holding and transfusing? And then at time of transplant, how are we going to manage patients who come in who've taken apixaban 12, 18 hours ago? And, when do you want to give the PCCs? Do you want to give it at the beginning of the case, or do you want to wait until you get into the OR? What is the dose that you're going to use? We can't use Indexa. I think most people probably realize that because then the heparin in the OR won't work. So, I think we're interested in getting rolling with this, but we're not going to do it until we have locked all of that in so that when patients come in the middle of the night, you've got to have your plans ready that everybody's agreed to. And you're not trying to have a group phone call at 2 a.m. to figure out how you're going to manage, that transplant. So.
Very good points. So with that, it is 4 p.m. So as we conclude today's webinar, I'd like to thank our 3 speakers for their presentations today. Also want to remind everybody that this webinar is available for CE credit. You should be getting an email within the next 24 hours with information on how to claim that credit. So be on the lookout for that. And thank you all for attending today's presentation. We're wishing everybody a great rest of their afternoon.